Thank you. I'll present our results from our local quality registry and we'll also look at the results from the different SI joint implants that we're using. We have no conflicts of interests and no disclosures. As we all know, there are very many available implants for minimally invasive sacroiliac joint surgery. Its use has exploded and the popularity has exploded, although there are varying quality on the documentation supporting their use. We've done the RCT that Thomas just talked about, which showed that we could not prove fusion to be superior to sham, and that we had an NRS reduction of 2.6 points in the surgical group and an ODI reduction of 4 points in the surgical group. And the clinical magnitude was, of course, much less than the RCTs from the US and the EU, which showed NRS reductions of 4.3 to 5.3 points and ODI reductions from 26 to 30 points. However, most of the time we use these implants in daily practice. And how does it work when you try to evaluate our patients from day to day? Well, registry data is very different from an RCT setting. There are no inclusions criteria on how or which patients are selected to surgery, apart from the criteria that the surgeons set themselves. And then at some stage afterwards, you'll have one or several follow-ups, and it's dependent on the surgeon or some system to gather the patients that you're following. Furthermore, you have no impact or very little impact on what happens with these patients between A and B, and you also don't necessarily know all the additional treatments that these patients are undergoing between the surgical fusion that they received and the follow-up that you're doing at some stage after your surgery. So as Thomas previously said, there are different types of registries. And many countries, at least in Scandinavia, have national spine registries. The door to be registered in a national spine registry is the operation note by the doctor. So the patient does not have necessarily to sign the informed consent. They do not need to fill out the baseline questionnaire. And then they receive these questionnaires at 1, 2, and 5 years in the post or by email automatically by a computer. So there can be problems with compliance. These are, of course, standardized questionnaires that are focused on low back pain and spine surgery and not necessarily specific for SI joint fusions. However, with our local quality registry, we tried to make it more specific to SI joint pain. We still have the same sort of prompts as in the spine registries in order to make them more comparable. But we have a much higher compliance because we more or less give the questionnaire to the patients hand in hand whenever they come for their surgeries or injections and workups and follow-ups afterwards, which means there's a higher compliance and they're also more specified towards their SI joint pain and their happiness with the fusions that they receive. So that's the difference between the Swedish spine registry and the Norwegian local quality registry. So we also did up the Swedish spine registry 2 years ago and found that they had a reduction of NRS of 2.3 points and ODI reduction of 15 points. And 70% of patients reported to be better than prior to surgery at follow-up. And these patients had no prior spine surgery performed. So what can we learn from our local registry? Well, first and foremost, we'll just do some fun facts about Norway. This is Norway in red, Japan in green. Funny enough, Japan, Norway, and the state of California are exactly the same size. However, the population is somewhat different. Norway has a population of 5.6 million people. Japan has 20 times the amount of people as we do, so you have a population of 124 million, and the state of California has 34 million people living in them. Norway also has a public health system, which means that most of the health services you receive are paid for by the state. We have a long and large country where you have to travel long distances in order to get specialized healthcare, which is also sometimes centralized to Oslo. So our local registry is localized in Oslo, where Thomas and I work. It was initiated in 2017, and we've registered all the patients who've been operated with SI joint fusion since 2015, and there were no patients who were operated with this method prior to that year. Seeing as we're the only two surgeons performing this sort of surgery in Norway, we have national coverage. So we pick up all the patients who are operated for SSI joint fusion in Norway. We are only two surgeons and we only do these operations in one hospital by our standardized method. So in Norway, we have used iFuse on the left, and then we converted or tried out Rialto for a couple of years. And in the 10 years that have passed, we've done 113 surgeries. Out of these 113 surgeries, there are 98 patients who have both baseline and 2-year data. And just for fun, we also have 56 patients who have 5 years follow-up. That's just very preliminary results. So if we look at our 2-year outcome data, this is what we have of outcomes. We have pain, NRS in the operated SI joint. They have their self-reported satisfaction. We look at ODI and pelvic girdle questionnaires for physical function and disability. And they also report their health-related quality of life by the EQ-VAS scale from 0 to 100. Methodologically, we looked at the change in PROMs, and then we've also looked at how many improved or felt better using minimal clinical important difference, which is either a set absolute numerical change or a percentage reduction in score. And MCID represents the smallest improvement considered worthwhile for a patient to undergo the procedure once more, or easierly said, it's the concept of improving or feeling better for the patient. Whilst patient acceptable symptom state PAS is the concept of well-being, or if the patient is feeling good and defines the highest level of symptoms beyond which patients consider themselves well. So in our registry, we have a large percentage of women, 92%. Their mean age is 46 years. They have a normal BMI of 25. 35 out of the 113 have undergone bilateral surgery. 32 have gotten the cylindrical threaded device, Rialto, and 66 patients have had the TTIs, which is the iFuse. And you can see their baseline PROM values at the bottom. So if we look at pain, their NRS in the operated SI joint is reduced by 3.2 points. The global pelvic pain is reduced by 2 points. And if we go to the improvement in satisfaction, we can see that around 60% achieve the PAS value for NRS in the operated joint, whilst if you ask them for their entire pelvic pain level, only 41% reach a patient acceptable symptom state. 60% reach the 30% improvement in outcome for the specific NRS sacroiliac joint pain, whilst only 50% for the global pelvic pain. And if you look at MCID, 70% reach the cutoff value for the specific SI joint pain and 55% for the global pelvic pain. For ODI, we showed a reduction of 13 points. And pelvic girdle questionnaire, they have an improvement of 21 points. And we see the same again, that there is a low percentage who achieve PAS. 50% have a 30% improvement, and 45% achieve MCID for ODI, and it's quite similar in the PGQ group. As for their health-related quality of life, they have a slight improvement of 13 points here as well. And 50% reach the 30% improvement in outcome and MCID for EQ-VAS. So these are the objective PROMs. So what do the patient themselves report? Well, it's the same as we've seen in our other studies, that around 72% report that they are either somewhat better or much better. And then we have some patients who are unchanged, worse, or much worse. And if we look at how this withholds for the 5-year follow-up, we see that it's about the same at 5 years. So it doesn't change that much from 2 to 5 years. If we look at outcomes by implant, we have, these are not matched in any way, so this is just preliminary results. We have 66 iFuse patients and 32 Rialto patients, and there doesn't seem to be any difference in the outcomes between these two groups. They perform similarly between Rialto and iFuse in regards to pain and physical function and health-related quality of life. If we look at the revision rate, for the iFuse patients, we have a revision rate of 9%, and for the Rialto patients, it's slightly higher, of 16%. It's not statistically significant, but there might be a tendency that Rialto seems to need more revisions than the TTIs. So how do all these results compare? The American RCTs showed, and the European showed a much larger clinical magnitude both for NRS and ODI. However, all the Scandinavian studies that we've looked at seem to show similar clinical improvements. So in the registry study where they had no prior spinal surgery, we had an NRS of 2.3 and ODI of 15. After prior spinal surgery, some colleagues of ours have looked at that as well, and they show poorer ODI than those who have not been operated in the spine before, which is also has been shown before. And similarly, the Norwegian RCT and the Norwegian registry show similar effects on NRS and ODI. Thank you.
I'm unfamiliar with PASS and how you ask patients that, because it looks like the PASS is designed to take other sources of pain out of the question and just concentrate in the SI joint. Is that?
No. The PASS is you define what level, how high a level of symptom score the patients can have. So say if you have a pain level of 5,
Yeah.
do you think that's worthwhile living with? And will you be satisfied with that result if that's the end result after your surgery?
Okay.
So it's the cutoff values that are stated here are from low back pain studies. So
Okay.
they do validation studies to find the PASS values for the different problems.
Okay.
Yeah.
Okay. Question, Jeff.
Just a comment, just thinking back to the hip presentation yesterday, it almost seems like the similar kind of results they're seeing with the hips, about 2/3 had improvement, meaning they met MCID. So it's not like we're really bad actors here trying to treat the SI joint, even the hip surgeons have their set of problems.
And it's, or at least in Norway, it's the same with the spine registries. So around 70-75% of patients are happy with the surgery that they've undergone.
I don't have a question for you, but it was the same as you said. Is this results good enough? Because we get these questions in Norway, 10% get worse, and is this actually good enough? And compared to spinal fusion, it's quite comparable because we treat pain. It's hard to make the right diagnosis. We miss sometimes, we hit it sometimes, but this is our practice. Is it good enough? Do you think so? Should we continue with these numbers?
I was going to ask, how do you take this data and how has it changed how you counsel your patients? I'm guessing it's different than it used to be.
Yeah, but I think it's really difficult anyway, because now I feel like an expert, and you're a perfect example of a patient that should be perfect, and they come back, I'm not happy at all. Right. And then you operated a catastrophe of a patient, and she's 100%. So it's very hard to understand this.
Well, I think we have to continue to do surgery because still there are so many that are improved. I think that is the important thing, to look at from the other side as well. Actually, if we only do those really perfect patients, and then we have maybe 90% good result, but not 100, doesn't exist. But if we don't take those really bad ones, and who really also get good, we take away people from the life, because that is the case. I say it is young people, and they have a long life, and if we give them the chance, they will manage to have a better life. But not everybody. But I think we have to offer them. That's my opinion.
I think what we're not struggling with, but what we're questioning is how do we select better than what we do now? And should we select better, or is 72% happiness, satisfaction from patients, is that good enough?
And now we have 98, 58, 184, 68. Now we can actually do some prognostic factors, and we're going to do that now. So hopefully we can get some ideas from that, but usually it's quite boring reading because it's the same prognostic factor every time we looked at it. So I don't know if we can manage to find any Yeah.
So another thought here is looking at the economic impact and the cost effectiveness, and looking at it from the economic side. Is it worthwhile to society for you to continue what you're doing? And maybe ask the question that way, and maybe you have good enough data to parse that out.
That's what we see in Norway, is that the patients who are partially or still full at work, they have a tendency to go back either full-time at work or not. If you are on 100% disability leave and you get your disability leave paid from the state, and that's kind of been that way for 20 years, it seems that that might be a part of the patient's personality. So it's difficult to kind of go back into society and contribute, because it's so kind of defined that I'm disabled and I've been that for so long, so I can't get well at this stage. That might also be.
It's the same day. If you get the surgery in Norway, you're actually so terrible that you deserve the disability leave.
Yeah.
So you don't get them back into work.
But we get
So-
some into work.
Yeah, some
But
we get
very
into
few,
work.
yeah.
So
Thank you, that was outstanding. All right, thank you.